Thank you, Dr. Sathir, and good afternoon, everybody. The first step in evaluation of a patient, first step in rehabilitation of a patient with low vision is to do a complete low vision evaluation. And the objective is to enable patients to maximize their remaining vision through use of adaptive devices and techniques. The low vision evaluation can be divided into 6 parts. We'll go through each in some detail. It's functional history, education and emotional support of patients, assessment of the visual limitations, determination of assistive optical and non-optical systems, recommendations for rehabilitation and follow-up. A good functional history is very important to know the patient's goals, visual needs and goals. Like in most of the patients with glaucoma, the highest valued functions are reading and seeing details and also mobility outside the house. Again, it's very important to assess how much the patient knows about the disease, and it's very important to help develop patient realistic expectations, help in eye care management, and also helps in the success of rehabilitative approaches. And now the most important part, assessment of the visual limitations. It's extremely important to measure distance and near visual acuity accurately. For distance acuity, it's always better to use the ETDRS chart. The advantages are you can move the chart closer to the patient, 1 meter, 2 meter, 3 meter, 4 meter, and there are several subdivisions between, like for example, between 660 and 636 there are subdivisions. The advantage is it's especially useful in compromised visual fields, and finger counting becomes it's not very accurate, 1 meter, 2 meter, and you also can't do it in a severely compromised visual fields. Again, similarly, you have various near vision acuity charts. What we use in our clinic, our hospital is the M unit system, which is incorporated into the Lighthouse near visual acuity test. There is the whole range is from M1 to M10. M1 is what the patient will read, a normal 6/6 distance or an N6 patient will read, and M10 is what is the maximum visual disability the patient is going to have in this chart. Contrast sensitivity is also in visual acuity testing. Usually the optotypes are in maximum contrast. This may not be the reason. This may not be the cause. In day-to-day activities, you don't have so much of contrast, and measuring contrast sensitivity also will give you a more complete view of vision loss than visual acuity alone. Again, it's very important to know the density, the location, size and shape of visual field defects. If you have a dense central scotoma positioned to the right of fixation, it will be extremely difficult for the patient to read in a sequence. An inferior altitudinal defect, the mobility will be affected much more than a patient with superior field defect. Color vision is also important. Good color vision may be required for the patient's work setting. Patient may be concerned about matching items of clothing. So you need to have adaptive approaches for all this. And distance refraction. Extremely important to do a careful spectacle refraction. Aim for very high accuracy with retinoscopy, because subjective refraction is going to be difficult for low vision patients. And it's surprising that conventional spectacles may be the only optical system that the low vision patient requires. And always do a monocular refraction, then a binocular. A slight binocular imbalance will itself be you might have a lot of difficulty. The patient may not be able to, his visual acuity will go down with a binocular imbalance. Always aim for clearest single vision with use of prisms, isoconic lenses or fogging lenses. Near refraction is probably the most important part of any low vision evaluation, and majority of the patients wish to be able to read again. This Kestenbaum has in the past, this is a very useful formula in which the reciprocal of your best corrected distance visual acuity is going to be the number of diopters that patient will require to read ordinary print. So if a patient with 660 of best corrected visual acuity will require 10 diopters to read print. Usually most of these low vision patients will require high plus reading spectacles. Usually they prefer to have single vision reading spectacles, not add bifocals. But the problem is the higher power you go, the shorter focal length reading material has to be kept much closer to the face, and you need to have basin prisms incorporated to overcome to have a binocular visual acuity, and also to overcome the problems, the amount of convergence required to read at close distance. This is the typical This is a typical prismosphere where you have the basin prisms at the nasal part. So there's a limit to what we can go. For plus 10 diopters, you can use a prismosphere. Anything more than plus 10 diopters, we have to go for aspheric glasses for reading. Again, handheld magnifiers are used by patients. Convex lenses have a handle, portable, easy to manipulate for viewing eccentrically, and usually patients use this for short-term tasks. They are inexpensive. They can't use this for prolonged reading. Usually if you want to look at the MRP in a store, or you want to look at the expiry date of a medicine, this will be useful. Handheld magnifiers, they are convex lenses, and a disadvantage is a reduced field of view, and especially difficult in people with hand tremors, poor hand coordination. Wide range of power, sizes and shapes are available, plus 3 diopters to 20x. Many of them have their own illumination source, held at correct focal distance to obtain maximal power. You have stand magnifiers also for patients who have difficulty having poor hand-eye coordination. There can be stand magnifiers. Stand magnifiers is a dome magnifier where the light is diffusely focused on the reading material. And then you go have the video and the electronic magnification system. The video is not playing. Okay, I can save time here. It's got pocket for people who there's pocket video magnifier also available. The advantages of this video and the electronic magnification system is it provides maximal contrast. There's reverse contrast polarity. You can have magnification either in white or in black. It's okay. I don't need the video. Telescopes are not very useful for the glaucoma patient. Telescopes are usually for just spotting at a distance or for sedentary viewing. You can't have a telescope for a glaucoma patient and ask him to go around. So field expanders also, our low vision clinician was telling me he has very little success with field expanders, especially even Fresnel prisms for glaucoma patients. So this is typically an LVA trial. For more than 660 you can have high add bifocals. For 660 to 360 you can have till plus 10 you can have prismospheres, then aspheric glasses above plus 10, and less than 360 close circuit TV, hand magnifiers, stand magnifiers. So we were talking, these are all optical. What we are talking about till now were optical devices. Now you also need non-optical devices. It works in conjunction with the like simple things like something called an approach magnification or magnification of nearness. In an auditorium, if you sit in the front, you see better. In a classroom, you sit in the front, you see better. Also, you need the light to fall on the reading material. You need most of these patients, a reading stand will help for prolonged reading. This is a typoscope a low vision patient uses. It's a line guide to isolate a line of print, reduces glare from the surface of the white page. Again, for these are rectangular slits which the low vision patient uses. It can also combine with a bold black felt pen, which is very useful for people with low vision to write. Again, large print types are available. Reader's Digest has a large print type. The low vision patient uses for currency notes. So ultimately it's going to be a combination of optical and non-optical devices. The patient here has spectacle magnification. He also has a handheld magnifier. He has good illumination. Here this patient is using just a handheld magnifier and good illumination. Coming to the social benefits of patients with low vision and glaucoma, these are the categories of visual disability as proposed by Ministry of Social Justice and Empowerment. These are the categories for visual disability for compensation in India. A patient with 6/6 vision in one eye is not visually impaired in any way as far as benefits are concerned for that patient. He has to have at least a 40% handicap to get some social benefits. A 40% handicap is less than 6/18 in the better eye. Less than 6/18 in the better eye. And these are some of the concessions offered by the Government of India to blind persons. Indian Railways offers 75% concession for the blind person and the escort in all first, second, sleeper class tickets. Indian Airlines 50% concession on all domestic flights, single trip or round trip. But here the escort should pay full fare. There are postage exemptions like no postal charges for transmission of blind literature packets for the use of the blind addressed to an officially recognized institution for the blind. to inland or foreign destination, provided a surface route is used. Up to 7 kilograms can be done, but not by air mail. Telecommunication, again on a priority basis. Educated, unemployed, visually impaired or blind people are given STDs, PCOs on a priority basis. They have to have an 8th pass in the rural area, matriculation in the urban area. They even have a 50% rebate on telephone facility. Again, there are customs concessions available. Conveyance allowances by the central government of India. Income tax concessions. Section 80D gives a deduction in respect of expenditure incurred by an individual on the medical treatment, training and rehabilitation of handicapped dependents. There's a beautiful article in the IJO where Mrs. Jose has given all the social benefits for visual impairment and given more stress on glaucoma also in this patient. Employment, 1% vacancies each in government employment, grade C and D posts reserved for blindness, low vision. There are 47 special employment exchanges in different states, and it's in recaning of chairs in government offices, they say should be done by visually impaired people, provided there is enough work for them. There's economic assistance scheme for the integrated education. They give a lot of assistance for integrated education for school children. A lot of welfare schemes available. If you can go into this site, it gives everything about National Institute for the Visually Handicapped, Dehradun. It gives everything about social benefits. And see this slide. Alan had shared this with me. Low vision services, they say, is more than just prescribing magnifiers, but this American Journal of Ophthalmology article in '99 showed that even now, spectacle magnifiers, directory of services, these are most important services available by the low vision. And what should we be doing? Concept of glaucoma care needs to change. The doctors and patients need to realize that low vision rehabilitation will help. The problem is there's so much of work on how and when disability occurs, but very little work on how it can be improved. And that is where we need better systems to administer rehabilitation. Thank you very much.